All right.
This is such an embarrassing one, man. So this question was just asking, like, which of the following best represents the probability that he or she will survive for 4 years? And
Mm-hmm.
literally,
Mm-hmm.
they just have the patient survival at this interval, and it was just 0.901. I was, and I know that you've said before, like, they're not trying to trick you, but I
Yeah.
was like, there's no way. And so I thought it was like, oh, you have to get past year one and then year two, year three, year four. I thought so, like to do that, it'd be like an 80% chance times a 70, 87.5 times a 90 times a 90.01. And so I went with that one.
Gotcha. Yeah, man, I would say, keep it, keep it simple, right? I always say, sometimes when you read these things, right? Best. So this is how I think about it, right? For this kind of question, right? A lot of it is memorization with biostats and things like that. But when you read something like that, it's like, what is the probability that he or she will survive in 4 years or for 4 years? There is no formula for that. You know what I'm trying to say? Like in your
Yeah.
mind, you should be like, oh, there's no formula for that. So then the question, if you were to rephrase this question, the question is pretty much asking, do you know how to interpret this data? That's all it's asking you, right?
Hmm.
So that's pretty much it, right? So if a patient survives
Yes.
for 3 years, which of the following best represents probably he or she will survive for 4 years, right? And so you just kind of take the
The number
percentages.
that it says right there. Yeah.
Yep. Yep.
Oh, this is very frustrating. I always get these switched. So it was asking like this basically this 20-year-old woman came in and she's having pain with sexual intercourse. And she had a spontaneous vaginal delivery 5 weeks ago and is currently breastfeeding. It says vaginal dryness and atrophy. And it says which of the following is a decreased concentration of of the following hormone. And I think what I was thinking was like that progesterone is going to increase the or like maintain the lining. And so if that was decreased, I think it only really maintains it necessarily during pregnancy and like, but anyway, I was under the like, understanding like it's going to maintain the lining of the endometrium, and if that's gone, it's going to, and it's also like what encourages like spiral arteries in the uterus. And so I was going to say like if it's not there, it's probably not going to be very um it's not going to be like it's going to be showing dryness and atrophy. And so I was under that impression.
Gotcha. Gotcha. A couple things here. Okay. This is a learning point for other things too. Okay. Because there's a whole host of questions that deal with this. So that's why I want
Mhm.
to kind of draw and kind of let you remember this, right? So I want you to remember that if you are postmenopausal, okay, you end up having like a lot of times you end up having like vaginal dryness, right? Vaginal atrophy, right? Sometimes the skin starts becoming very, very dry and flaky, right? And that's because you lose estrogen. Okay. Estrogen allows that area of the female body, right, to kind of stay moist, plump, right? And
Yeah.
things like that, right? And so just kind of remember that, right? So postmenopausal women, right? Or right, once you hit menopause or postmenopausal, right? A lot of times, what do you think the treatment for vaginal dryness is?
Is it just to give estrogen back and through what ¿cómo se llama? The OCPs?
So let's talk about this, right? Would you want to give straight estrogen to females that are post menopausal, like estrogen pills? Not a lot of times, right? Because what happens if you give too much estrogen?
Um, oh, it can lead the risk to endometrial carcinoma or cancer.
Yeah, like cancers, right? Any kind of hormones that you give like individually, right? So a lot of, if you think of it, a lot of over the counter contraceptive pills, they're combined like estrogen or and progesterone or just progesterone. Estrogen alone is not usually super good, right? In high quantities because it can lead to cancers, right? And so actually, right, for vaginal dryness, the what it's actually estrogen cream.
Estrogen cream.
Yeah, topical.
Oh wow, I never heard of that.
Okay. And so, yeah, I know this is more, you learn kind of, during your clinical rotations or things. But the reason why I'm connecting it for you, right? Because now when you put that all together, you're like, oh, of course, right? You have vaginal dryness and atrophy. It has to be estrogen, right? Because in the
So
future, go
yes.
ahead.
When you're looking at like I say a woman who's coming in here and they have like the symptoms of postmenopause, are you looking at like so vaginal dryness, hot flashes, all these things like atrophy? You're thinking like in a young woman, for example, 20-year-old woman, you're thinking, okay, they must have decreased estrogen because that's what normally would happen in a postmenopausal woman, but it
Exactly.
shouldn't happen here. And so this
Yeah.
is
So
okay.
yeah, exactly. So what I'm trying to do is I always try to connect things, right, on a motif standpoint. You know how I am, right? So if a woman is having vaginal dryness atrophy, right, these are the same symptoms as someone that's postmenopausal. And postmenopausal women, right, that have these same symptoms is due to lack of estrogen. So you can deduce pretty well there's probably a lack of estrogen.
Perfect.
Okay.
Perfect. Okay. 15-year-old boy had nasal polyps and bronchospasms. It says what the drug most likely to inhibit which of the following enzymes? The drug is most likely to inhibit which of the following enzymes? I didn't know. I thought actually, I don't know what I was thinking on this one. I remember not knowing what drug to give.
Okay. So let's talk about this first. Did you get the diagnosis? The diagnosis first is always what you want to start with,
Nasal
right?
polyps and bronchospasms.
Yeah. So this is an ENT question, so I got to teach you this well because they do like asking this still.
Yeah,
Okay. So when you're thinking of any time that you have a pediatric patient under 18 that has nasal polyps, you're either thinking cystic fibrosis,
which is not the
right?
case here.
Yep, not the
Oh,
case here, or AERD, okay, which is aspirin exacerbated respiratory disease, or it used to be called Samter's triad, right? We don't call that as much anymore. But these are the two diagnoses that you're really thinking of, right?
mm.
So you have nasal polyposis, so you're thinking it's one of these two, CF or ARD, right? And then obviously bronchospasms, right? You're like, oh, okay, bronchospasms is the same as asthma.
Really?
Yep.
Let me write this down. Sorry, I'm
Okay, bronchospasm asthma is just an overreaction of your bronchioles, right, to kind of allergens, right?
okay. So
Right.
okay, yeah, exactly. Just asthma. Okay.
Yeah, so that's just asthma, right? So if you have asthma plus nasal polyps, okay, that's going to equal, right? That's 2 out of 3 of Samter's triad. Okay, so you assume that they probably have the third of Samter's triad, which is aspirin insensitivity, right? So the 3 things of Samter's triad is aspirin, asthma, nasal polyps. Okay. So then, right, they're gonna say, oh, the drug is most likely to inhibit, right? And because they're after taking a certain drug, right? And so kiddo is probably allergic to aspirin, right? And aspirin is a COX inhibitor, which is B.
Yes, COX-1 and COX-2 irreversible inhibitor.
Yep.
Okay. Yeah.
Okay, so just remember that ARD, right? Aspirin exacerbated respiratory disease. And this is part of the easiest way to remember this is that AERD, right, or Samter's triad, either one, right? It is part of something called atopy. Okay, do you know what that word means by any
I
chance?
kind of I don't really necessarily know what it means. I just know that it's like a group of conditions that can be like termed to like allergens or stimulant, like something to like
Yep,
almost
that's
mess with
it.
you like that. Okay.
Yep, that's all it is, right? So atopy, exactly what you're saying, right? Deals with like an allergic profile, right? So, people with ARD will likely also have like eczema, seasonal allergies, right? Sometimes EOE, right? Eosinophilic esophagitis, right?
Yes.
So all these things that deal with allergens, right? Strauss, things like that you can have, right? So just in your mind, right? When you have we call it allergic profile or AKA atopy profile, right? Then they all go together, right? So that's something you think about and group some diseases together.
Cool. I actually have never really heard of even um when I was reviewing this, I've never heard of aspirin exacerbated respiratory disease before.
Mm-hmm.
So again, let me just make sure that I have this like down. You see nasal polyps, you're thinking, okay, that's going to be rather a young kid with nasal polyps. You're already thinking about cystic fibrosis or AERD, right?
Mm-hmm.
Then you
Mm-hmm.
see bronchospasms. That's 2 now of the 3 of Samter's triad, which is
Mm-hmm.
aspirin-induced respiratory or aspirin exacerbated respiratory disease. And you're thinking it's probably something to do with aspirin. So the drug that's most likely to inhibit this is going to be B because it's a COX inhibitor, COX-1 and COX-2.
Yep. Exactly. Exactly. And this is just a side note to complete the circle, right? This goes on to more of a step 2 and also a little bit into ENT. So a lot of these kiddos, right? A lot of these kiddos are going to need surgery to kind of clear up their nasal polyp, right? But one of the key things to keep these nasal polyps down is you're going to want to desensitize them to aspirin. That's a key thing because
Mm.
if they're not desensitized to aspirin, right, they're going to flare up still. So what you do is you give them like super low doses and work them way up, obviously not to cause anaphylaxis. And then they have to be on aspirin their whole life with like a decent dose. And so then your body's like, oh, okay. So then it like gets used to aspirin, right? And then it'll decrease your nasal polyp so it doesn't recur as much. So
Okay, cool.
something to think
Just a
about.
quick question, unrelated to this, but like I thought that aspirin at lower doses, middle doses, and high doses all have different effects on the body.
Yeah, they do. But when you're this is think about it like this, right? Aspirin is not aspirin at this moment. I know that sounds weird, right? But when you're dealing with Samter's triad, right, or things like that, aspirin is like a big allergen, right? So if you think about people with allergies, right, what do you do to help them with their allergies, right? You're
Yeah.
building up their tolerance, right, with allergy shots.
Okay.
Okay, so you're doing the same thing with aspirin here, right? You're not using it for obviously, you're not using it for anticoagulation or anything like that. You're using it as a way to, oh, how do I desensitize you to the thing that you're super allergic to? Because when you're allergic to aspirin and you have this atopy like picture, you're gonna want to, keep spasming, as in your asthma is gonna be, super exacerbated. Your nasal polyps are gonna want to keep growing back. So how do you prevent that? Okay, so I'm gonna desensitize you to aspirin.
Very
So
cool. Okay.
yeah, so that's how, I mean, that's how, dealing kind of on a segue here, but that's how allergy shots work. And that's on my boards too for ENT. But allergy shots is, I'm just giving you an example, right? You start with a dilution, let's just say of 1 to 100, 1,000 of whatever allergen. It could be like, it could be grass, it could be pollen, it could be tree pollen, it could be certain nuts, right? And then, right, after like a month, right, you kind of give them a little bit more, right? Let's say it's 1 to 500, right, dilution, right? And then you
Mm.
get them to 1 to 300, and then because you can't bump it up too fast, because then they're going to get like an anaphylactic shock if they're super allergic to it, right? So
Yeah.
you go slowly up into the point, right? I mean, and this takes 3 to 5 years, right?
I was about to say it's gonna take a long time, I'd
Long
assume.
time, long
Yeah.
time. But after you're done with these allergy shots, right? If your body is, I'm just throwing a random number. If your body is used to something like, let's say 1 to 25 dilution of a certain allergen, but then the allergies in the air is actually something like 1 to 500 dilution, then
Oh,
you'll
you're
never
chilling.
get allergies anymore, right?
Yeah, you're
Yes,
great. You already were exposed to what you would have been exposed to 3 years ago, and you're like, no, this is nothing. I don't feel anything.
exactly, exactly. So kind
Yeah.
of the same idea for aspirin.
I just didn't. I looking back at this, like, I was like, oh, I should have got this one right. You can kind of see there's a graph here, and it's basically just asking when they inject a drug at X, this is what happens, and the phrenic nerve is just continuously stimulated, I guess. And
Mhm.
so I was kind of like, I really don't even know what's happening here, and I just made a guess because I was like, I really don't even know what most of these do. I knew
Sure.
lidocaine is obviously like an inhaled, or maybe it's not inhaled. I think it's an anesthetic. And so I was like, no, I don't think it's going to be there. Pentobarbital, I was like, I don't think it's that. I didn't remember what tetrodotoxin did. I know it's like from the pufferfish or whatever, or like the
Yeah.
sushi, but I didn't know what it did. It's like maybe it's that. I just went with
Sure,
it.
sure. So this is a tough question. It's kind of tricky. So if you break it down, it makes sense, right? Let's start with the airflow, right? Airflow just means you're breathing in and out, right?
Hmm.
So breathe in, breathe out, breathe in, breathe out, right? And then all of a sudden you give the drug and you're no longer breathing. Okay. So there's multiple things that causes breathing, right? There's your muscle, there's the nerve that triggers your diaphragm, and then your diaphragm to move. Those are your two things that you need to increase negative intrathoracic pressure to pull in air, right?
Hmm.
So then you look at your phrenic activity, right? It's able to be on, right? When you inhale, right? So you contract your diaphragm, then it relaxes, it pushes it out, and then repeat, right? And even after you give your drug, right? Your phrenic nerve is actually on, it's still on. Okay. So from these two alone, without the abdominal pressure, from these two alone is that there is a drug that does not affect the nerve.
Oh,
Does it
drug
make,
does not affect the nerve.
yeah, because the nerve is still firing, right?
Oh yeah, it is.
Okay. And then you look at the abdominal pressure, right? It's moving, right? It's moving, the diaphragm's moving, then you give the drug and the diaphragm is no longer moving. So you need a drug, right? That is a muscle, right? That is a muscle paralytic. Does it make sense? So the only
Yeah,
one that is a muscle paralytic is your curine drugs.
the curarine, the acetylcholine the acetylcholine esterase.
Yep, it
Weird.
blocks the muscle, but it doesn't paralyze the nerve, right?
It blocks the muscle, it doesn't paralyze the nerve. That's really good.
Yeah. So things to think about. That's how you kind of work through this question. It's tricky for sure, but they're trying to get you to think, oh, okay, so nerve is intact, but muscle is not firing or muscle is not contracting, meaning it is a muscle paralytic. So,
Yeah. Interesting. Okay, that's cool.
alrighty.
So I knew this one was talking about, so it was talking about basically what the mechanism of action of tamoxifen was. And I just knew it was a SERM, a selective estrogen receptor modulator. And I was thinking, is it going to downregulate the receptors or is it going to competitively inhibit? And obviously I got rid of everything else besides that. And I was like, it's a modulator. Maybe it's because it's a modulator, it downregulates instead of inhibits. So yeah.
Okay. Perfect, perfect, perfect. Let me see here. Do you have more problems? This one also is a little bit more biochem, but I was going to ask you, did you have more problems with the first two sections or the last three or last two? Do you
I
remember?
definitely missed more in the last. I missed like the first. I missed a lot in the last one. I remember
Okay,
that.
let's actually start. Let's go through kind of the sections 3 and 4,
Okay.
if you don't mind. Let's go through there.
I hate that they don't have like a way to jump around.
I think they do. Do they allow me to do it? Oh,
No,
mug.
you have to literally just click it, dude. It's annoying.
That's really annoying. Okay. Okay, let's start on section 3 here.
This one was kind of embarrassing that I missed. So it basically just said like which one of these will provide the greatest amount of energy in the form of ATP when it's basically like broken down or like metabolized.
Mm-hmm.
And I think this from like organic chemistry back in the day. Like if you rip apart two hydrogen atoms, it'll create, and it takes more energy to rip them apart. So when you metabolize them or hydro whatever, you're going to develop more ATP because it's a higher energy reaction.
Um, well, if you think about this, right, this is actually, you can break it down even like a little bit easier, right? If you think about like how your all the mitochondria, all your Krebs cycle, all that stuff, right? You're just passing around H plus ions, right?
Yeah, NADP, NADH to
Yep,
NAD.
yep. That's all you're doing, right? You're converting kind of these gradients, right? And pushing H plus or protons down a gradient. That's how you create ATP. So that's kind of what they're trying to get at,
Yeah.
right?
Simple one, I should have got that one right, but it's okay. Um, the isopropyl fluorophosphate is a potent inhibitor of acetylcholinesterase, reacts with which of the following specific amino acids. I just didn't know this. This is where I feel like it's like you know it or you don't. I don't know how you
Yeah,
figure this one out.
yeah. This is just you know or you don't. I wouldn't say this is super high yield. It's yeah. I mean, I don't personally remember
I spent
this.
like 20 seconds on it because I was like, I don't know this. And it's like,
Yeah, but on a test taking strategy, that's exactly what I would have done, right? You look at it, you're like, what the heck is this kind of question, right? And then you just pick an answer, you kind of learn from it. What are the odds of this showing up? To be honest with you, very rare, right? To me, this
yeah,
is not a high yield topic. So, on your test, this is just a learning point on a test taking strategy, right? On your test, you're going to get something like this, right? Please, 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 right? Don't spend more than like 20 seconds, 30 seconds on a question like this because you can sit here all day and it's not going to change, right? It's a,
exactly.
1 out of 5 chance, 20% chance you get it right, right? But, use your time for kind of those, questions you can actually sit and think about. This is not
Mhm.
one of them.
Um, okay. She had azotemia. It shows hydroureters and hydronephrosis. The most likely cause of these findings is primary carcinoma of which of the following? I was thinking, I remember reading somewhere that when you have like issues in the ovaries, it can also affect the ureters because I feel like they kind of run close to each other in the stomach.
Sure,
And
sure.
so I was kind of thinking probably the ovaries.
Okay,
But
so
it's
let me draw this out for you and then it'll make a lot more sense. Okay. As best as my drawings can, you know how bad they are. All
no,
right.
you're good.
All right. So you got some kidney beans on the side, right? You got your ureters, right? Okay. You have your bladder, right? And then you have
Yep.
your
Yep.
urethra, right? Okay, so that's, generally your urinary tract, right? And so let's just say, right, I'm gonna draw a different view, right, on a sagittal view. Okay, we're getting a little fancy here. How well I can draw this, have no freaking idea, but we'll try. Okay, so here's your, let's say your pelvis, right? In the anterior, you have three. I'm gonna draw three circles, right? This is sagittal, right? This is anterior to posterior, and this is a female. Okay,
Yes.
okay. So this is your pelvis, right? And so what's the organ that's most anterior for a female?
Isn't it the I'm sorry, the bladder?
Yep, bladder. What's in the middle?
The uterus,
Yep, and what's in the back?
the rectum.
Okay, good. Okay, so now you kind of understand the orientation, right? So the key thing is that the bladder is anterior. So if you can imagine, right, your uterus is somewhere here, right? And then your ovaries, right, are sitting something, let's just say, somewhere right here. Okay,
Yeah.
probably not completely anatomically correct, but around there. Okay, so let's the reason why I'm drawing this anatomically, it make a lot of sense, right? So it says bilateral hydroureters and hydronephrosis, right? Bilateral. If you have a ovarian mass,
It's not going to touch the other ureter.
bingo, right? It's only unilateral, right? So you need an obstruction that causes, right? That causes both sides to be enlarged, right? Not only both kidneys, but also both ureters. So what you're looking for is some kind of obstruction near your bladder. And so
Because
what
it's
is
the only place
what's
where they can actually like meet up and yeah.
exactly. So imagine this, right? If you had a uterine cervix, right, obstruction, is going to be something like this, right? Which is going to block kind of the outflow of your urethra. Then
Yep.
all this is going to backflow. And if all that's going to backflow, then you're going to have bilateral. It's the only one that can give you bilateral issues.
Yep. That's perfect. Okay.
Okay.
That's yeah. That seems like such a small insignificant detail at first, like the bilateral, but when it comes down to it, yeah, that's
Yeah,
the
just
only one that you
remember,
need, really.
this test is trying to give you all the details that you need to pick the best answer, right? But yeah, just think of it like that, right? On an anatomical, your ovary can 100% cause you unilateral hydroureter and hydronephrosis, but bilateral, unless I mean, in the medical world, is it possible? Yeah, I mean, if you have a teratoma that's like 20 centimeters, big in the ovary, then yeah, sure, right? But they're talking about what's the most likely case, right? So.
Hmm. Okay. Oh, this was frustrating. I knew exactly both. I thought fluoxetine was an SNRI instead of
Mm,
an SSRI because I remember
mm-hmm,
there was like two that are SNRIs, but I
mm-hmm.
was like locus coeruleus is norepinephrine, rhamnucleus is serotonin. I know this is an SNRI, so I'll pick locus coeruleus or coeruleus.
Okay, so another thing for you is just to let you know, right? This is playing the clinical test taking, right? Even let's say fluoxetine is a SSRI or SNRI, right? You're like 50-50. I'm not sure.
Mhm.
But you want to remember that SSRIs are your first line for major depressive, right?
That's crazy. Yeah, I just realized that. Yeah, yeah.
Yep. So you're like, it's most likely, right? You're talking about a clinical standpoint, right? So I mean, if you were to ask me, right, I wouldn't even think twice what fluoxetine is on a clinical question because I'm gonna assume that's a SSRI. Because why would they give a second line on a test? That's kind of mean of them, right? Like, tricky.
Yes, exactly.
So, but yeah, that's something on a test taking standpoint that you can kind of think about. You're like, okay, I'm not sure if it's a 50-50. Is it SSRI or SNRI? Okay, well, I do know that its first line is SSRI, so let me pick the answer that deals with SSRI. So that's more of a test taking strategy thing.
That's smart. Yep. Dang. Okay. Cool. I did not know this one at all. It said it was a weird question to me. The way they asked it to me was really weird. An experiment is performed in which an isolated segment of skeletal muscle undergoes isotonic contraction. So which of the following would determine the maximum rate of shortening? Well, that's a weird way to ask that. And so I got rid of the only answer that was right, which is kind of funny. But
Yeah, I'm not sure. I mean, I don't remember this question. Isometric contraction, which is generate the force without change in length. Concentric, the action shortening with the muscles cross. Right across the maximum rate at which muscle can shorten. Yeah, I didn't know this. This is something I guess you just have to kind of like once again, this is kind of a weird question. Lower yield, I would say, but kind of understand the general thing. It just says cross bridging recycling is a maximum rate which the muscle can shorten. Didn't know that, definitely for sure. So
Okay.
I
A
just
little
and
simple.
also understand what isocontraction is, right? You're not, you're staying in one spot and you're flexing pretty much, right?
Yeah.
Okay, work me
Oh,
through this one
very
here.
frustrating. It's just definitions here. It was basically the person with AFib. I knew that what meant. This person was, I think he's the one with AFib. Yeah, irregular pulse.
Yep.
And so
Yep.
I was like, oh yeah, AFib, very easy. It's going to be something that's going to like travel along.
Yep.
This is what's going to cause the issue because I think it was like mesenteric ischemia or something like that. Yeah, mesenteric ischemia.
Yep.
And I knew the diagnosis. I knew what caused it. I knew that. I was like, oh shoot, is the one that travels embolism or thrombosis? This is
Yep.
the stuff that makes me like frustrated when I get to a test because I get to this and it feels like I choose them wrong a lot of the times, but I'm getting better. I am.
No, no, you are improving. Don't get frustrated. I mean, I think this is actually a common definition that people mix up. I mean, I'll admit it. Probably for the first 2 years of medical school, probably even into my third one, I thought an emboli and a thrombus were like synonymous. I won't lie to you,
Yeah,
right?
for sure.
Which they're very similar, right? They're both clots, right? But embolization is a clot that travels, that moves, right?
Yep.
Right? And then thrombus, right, is a clot that stays and creates an issue locally, right? So they're both clots. But yeah, that's about it. But
So
yeah, you got the
yes,
diagnosis right. It's from the AFib. AFib breaks off, embolizes, clots somewhere else, and then causes you death, right, of the intestines.
exactly. And I got that whole thing down. I was like, oh shoot, is it which one is it? Thrombus. I
Yep.
got thrombus. And so yeah, yeah, I know it now.
Yeah, you won't miss it again.
No. Okay. So 35-year-old woman brought to the department for 3-hour history of sharp cramping in the right flank. It shows blood. Non-contrast CT is obtained and a renal calculus is found to be lodged in the ureter just above the sacroiliac joint. As this point narrows, the ureter passes it. Oh, passes the ureter as the ureter. Oh my gosh! As the point, the ureter narrows as it passes over which of the following structures? I just think this was an anatomy question that I didn't 100% know, and I had that question before about the ovary, and I thought, oh yeah, they're just re-asking this question.
Yeah, so this one, they especially cause pain, complication in the uterus. Yeah, this is kind of figuring out, what vessels they're especially talking about. Trying to think, is there anything else that I can give you? Let's see, launch from scene. No, I mean, this is an anatomy question, right?
Straight up, yeah.
Yeah, straight up. I mean, like, what is, when the ureter, right, is close to the sacroiliac joint, right? That's kind of low, right? And so that's going to be your external iliac vessels. So this is an anatomy question. I don't think there's any kind of clinical standpoint you can take from this.
Yeah. Um, it's funny when I see these pictures here, I freak out because I just people seem to really understand it, and I kind of look back at it. I think this was a pneumothorax in that like left lower lobe there. Um, but for some reason when I was reading it, I forget. Let me see it. 5 hours, shortness of breath, chest pain during exercise.
Yeah, so your diagnosis is correct. It is a pneumothorax.
Yes, I don't think well, now I know that, but like, I don't think then I was thinking pneumothorax because
Oh,
I
okay.
looked at this and I freaked out. But
So don't freak out. So work me through your work with. Don't look at the chest X-ray. Work me through the case here. What was going through your mind?
so I see a 25-year-old man come to the emergency department for 5 hours after developing shortness of breath and chest pain during exercise. See, already there, I kind of hazy of what chest pain during exercise is when it relates to the lungs. I always
Mm-hmm,
think, I'm fine when it's a older person, they have chest pain. I know the anginas really well. And so when I see chest pain during exercise, I'm thinking like pleuritic chest pain,
mm-hmm,
but
mm-hmm,
that's the word I'm thinking. I really don't understand. That's in my list actually for going over that today, but like what pleuritic chest pain kind of is and like what that would indicate. I don't even know
mm-hmm,
that's what this is like indicating here. But anyway, he has no cough or bloody mucus. He has asthma and major depressive disorder. And his current medications are fluticasone inhaler and albuterol. 110, he's 98. He's a little bit. Um, I wouldn't say he has high pulse. He's tachycardic and he has low blood pressure. Pulse oximetry shows oxygen 93. Cardiac examination shows S1 and S2 with no murmurs and no JVP. And then you see hemoglobin. I don't remember. I think hemoglobin's a tad. Actually, I think it's slightly okay.
Yeah, it
I
should be
think
okay. 13's fine.
pH is, I mean, barely alkalotic, and then PCO2 is low, PO2 is low. And
Okay.
so I don't remember. Okay, now if I look at it, I'm kind of thinking like there has to be something like not, there has to be some issue with ventilation. And
Okay.
so I don't, I remember looking at fluticasone and albuterol, and I was thinking like maybe that's like those are like kind of asthma medications.
Yeah, yeah. So
And
so
so
let's
yeah,
work through this, right? So this is a weird case, right? I mean, this if you know clinically super well, you can maybe get it, but you still need a chest X-ray. But 25-year-old male, so young, acute issues, right? 5 hours is acute,
yeah.
right? Chest pain during exercise, which is never good in a 25. That's something like you're like, what's going on? Because MIs and things like that usually don't happen in this age, right?
Mhm.
And then they give you risk factors of asthma and major depressive disorder. Then they give he's on asthma medication, big whoop, right? And then all of a sudden, right, he's tachycardic, tachypnic, right, breathing really heavily, blood pressure is low. So now you're like, oh, that's not good, right? Normal S1, S2, so the heart's okay, and then no JVD, and then obviously, right, he has, he's breathing really fast, which makes sense, right? Because he's blowing out a bunch of CO2, but he's not intaking a lot of O2. That's what I've kind of gathered. And then you have to kind of use this chest X-ray because it's going to give you more of a hint. If you look very closely, I'm not sure if you can see on my
I
screen.
can see it now. It's like this is what I hate about like chest X-rays. I just feel like to everyone else, it's like, oh yeah, 100%. How do you not see that? But for
No,
me,
no, no.
I can't see it that well. Like
No,
I
no, no,
don't
no.
know.
It's tough. It's tough. And so we'll go over chest X-ray. We'll go over chest X-ray for sure, and I'll tell you things to look for. But let's say you take a look at that. The reason why it's pneumo, right? And this, if you take it to a higher clinical sense of looking through this, if you have a young person with asthma, right, that means that he can have like an emphysema kind of picture, right, and that he can blow a vet like a bleb, right? So it's a spontaneous pneumo,
Uh-huh.
right? That's something that can happen, right? Usually it's see ruptured bleb, bronchus, fistula as a source, right?
Yeah.
But usually it's from trauma is usually what you see. But without trauma in a young person, they usually say that they're really skinny, they have some kind of asthma or emphysema, right? And if they cough or they're breathing really heavily, it can pop a bleb, right? What I mean by pop a bleb is you have a couple alveoli that pop, right? And then you leak out air, right, from within. Okay, but let's talk about chest X-rays. Does it make sense so far? Oh, where'd you go? Oh. Hey, what's up?
Hey, I don't know what happened.
Yeah, it's okay. But what I was gonna say is, I'm not sure if you caught, but the internal, right? You usually have a young male, right? A
Mhm.
lot of times they'll say they're skinny, right? Have some kind of asthma or emphysema-like symptoms, and then they can have this spontaneous bleb that ruptures, which is the alveolus, right? If you crack or pop one of these alveolus, it leaks out air, and so that's another way you can get a pneumothorax, right? The other way is the one that everyone knows of is if you have trauma, right?
Exactly.
Your rib is sharp, it punctures, or you have somebody take a knife to puncture this, right? That's the other way. But those are kind of your ways of getting a pneumothorax. But let's walk through kind of chest X-rays, like you were mentioning, right? So one of the key things to look for, especially anytime you're looking for a pneumothorax, right? You're looking for kind of what they call lung parenchyma. It's just fancy for saying lung tissue. Okay, lung tissue is going to have a lot of these like spickles of wispy stuff, right? Because it's not completely filled with air, right? It has the alveoli and whatnot, and so it's the tissue. And so if you look really closely, right, you see this shadow here. That's where the
Yeah.
lung parenchyma disappears, right? This is just all air, right? That's not normal. It
So
shouldn't
it's
all
really
be.
clear. It's really
Yep.
clear. Okay.
Super, super clear. Shouldn't be like that. Okay. Another thing you want to look for is your diaphragmatic, your diaphragm, right? Your diaphragm. So why is that
Hmm.
important? Because if you look at your
Um,
diaphragmatic angle, right? So this angle right here, if it's blunted and you don't see this angle and there's fluid, then you know that they have like pulmonary edema, right? That's something, right? Or if they have a completely wide out right here, that's like a middle lobe pneumonia or a inferior lobe pneumonia, something like that, right? But I
hmm.
always kind of quiz you guys so that you guys can see, so that you guys aren't intimidated by chest x-rays, okay? So talk to me kind of, what do you see? What am I drawing here?
Those are the clavicles.
Good. Okay. Talk to me. What is this?
It's called the something notch, the
Yep.
something notch. I forget what
Your
exactly.
aorta, right? Your
The aortic
aortic
notch,
notch.
yes.
Okay. What is this?
That's just the heart right there.
Okay, good. Okay, I know this might seem easy, but if you can orient yourself, you never kind of have to be scared about
You're
this.
right, it does, but the little like, I mean, for me, it's on my right. This little like it looks like a little like artery, like a large artery on the right side here, and his lower left towards the middle, like the esophagus trachea area.
This right here?
No, lower, like to your right now, or right there. That thing. It looks like an artery to me. It doesn't look like a heart. I don't
Yeah,
know.
so the reason why is the heart shadow is like this, right? But the thing is, because your lung is kind of, your lung is collapsed, right? Like this. And so now all this is together, so this looks weird, right?
Okay.
So
Yeah.
that's the only reason why. But take a look at here, right? So I trace this. What is this point called right here?
The oh, I don't know. I forgot. I actually completely forgot.
Yeah, that's your carina, right? The split between
Yes.
your left and right bronchus, right? And here's your trachea, right? That
Mm-hmm.
you need to be clear of. And this is a little bit harder. I always ask these things, right? Um, so what is this right here?
Is it just a scapula?
Yep, there's your scapula, and here's for bonus points here, right? Well, why is there a hypodense area down here? What is
A
that?
hypodense area. Um,
Why is it black down in this triangle here?
that right there. Man,
That's your gastric bubble.
it's a gastric bubble.
Yeah, it's underneath your diaphragm, and there's air. That's your stomach.
Really?
Yeah, so that's what's confusing you because there's some lucency here. That's just below the diaphragm. So that's just your stomach bubble. And sometimes you see it a little
Hmm.
bit further down here, but under the diaphragm, you know that it's your stomach.
So, okay. So technically the right lung in this picture is fine. Like this is like perfectly fine.
Yep, the right side is fine. The
And so
left,
the diaphragmatic angle should be at this little like very steep angle here, if that makes sense.
yep,
Okay.
yep, yep.
Okay.
Questions, concerns about that?
No, so also another thing, just because again, I really struggle with these. When you see blood versus like pus, is that all gonna appear the same? Is it just
Yeah,
gonna
on
be
the chest X-ray, you can't really see. I mean,
okay?
like I said, it's going to be hazy, right? Anything that's weird, they're not going to test you that detailed. I would say that their main thing is, remember when I told you on your first session with me is that all these images that they test you on, it's high yield images. Okay,
Mhm.
so they don't expect you. I mean, even these small little details that I'm showing you, right? A little bit of a deviation of your trachea, right? Sure, if you can see that, great, more power to you, right? You'll be able to see a little bit more, but really they're trying to show you kind of the main big things, right? Like, can you see the lung parenchyma, right? And here's air, right? But if you're talking about, blood versus pus versus pulmonary edema, right? All you see is white out here. You won't see your diaphragmatic angle. And so you
Yeah.
don't know which one that is. You just know something's wrong.
Okay.
Okay. Other questions? Good questions.
No, thank you. That's good.
Perfect. Don't be scared of chest X-ray. Just do it. Like I said, when you're looking at it, do it in a very systematic way. Can I see? Can I see my ribs? Can I see my clavicle? Can I see my scapula? Can I see my diaphragm? Can I see my costal vertebral angle? Is it sharp? If it's not sharp, then there's something there, right? Can I see my trachea, right? Can I see my heart? Can I see my aortic notch, right? These are the things that I'm working through. Oh, do I see the lung parenchyma? If you do, then that's not good. It's probably pneumo, right? There should not be a sharp distinguishing line here, right? Because
Mhm.
it should all be hazy all the way to the periphery. So those are the main things you're looking at.
Cool. No, very cool. Very cool. This one to me, I didn't like this question. It was basically this guy with diabetes.
Mm-hmm.
And it's like he's gonna have sensation. The pinprick and vibration is decreased. It's just like how would he most likely describe his like foot pain, basically? And I was thinking like I always heard it as like pins and needles, and so I thought of that as a sharp. I didn't like this question, but I didn't think it was well worded at least, or like well, because I feel like it's all subjective too. Like this is not like a guaranteed like someone's gonna say, oh yeah, every patient's gonna come and say it's burning, you know?
Yeah,
And so
yeah.
I don't know,
It's kind of interesting thing for sure. Yeah, it just says neuropathic pain or nerve pain is usually burning, I guess.
burning
Pins and
pain.
needles is usually actually, to be honest, pins and needles is better. For me, when I saw diabetic patients, which was a long time ago during my family med rotation, they usually call it pins and needles. Burning, I didn't hear too much, but yeah, they're just trying to get you to know that, sharp pain is like something different. They're trying to get you, do you understand what neuropathic pain is? But like I said, once you miss this once, you're not going to miss it again. So,
Neuropathic pain, yeah. I mean, I would just kind of describe it like it's obviously the nerves that are kind of like um that are having like pathogenesis with it. So I would always describe it kind of like as like pins and needles or like tingling, maybe.
yep,
That's
tingling,
kind of how I
exactly.
describe it.
Tingling and pins and needles. Sharp is more like usually when something's sharp, it's like really stabbing you of something sharp.
Okay.
Yeah, either that or what's the other one that's really bad? Trigeminal neuralgia. They
Oh
usually
yeah,
call
that's
it
sharp
sharp
pain.
pain.
That would be sharp pain. You're right.
Yeah.
Oh, okay. So actually, this would be great if we could go over this.
Sure.
um, when I was under the impression that when you have a inferior wall MI, that was talking about your posterior descending artery. But I think it's actually the right coronary, or like it's usually the right. It's right. I'm confused. I know that AVL, like what I know AVL is going to be left circumflex most of the time. AVR is going to be like I think left descending, left tier descending. But this person had like an issue, and it had like I think he said it basically said where is the AV node? Like what? Basically, the question is asking what artery covers the AV node, and I was under the impression that it was left anterior descending, but apparently it's posterior or the posterior descending.
The circumflex artery originates from the left main coronary lateral posterior subluxation. Deal something with this. It deals with the left dominant thing. This is like a trick question in a sense. But let's kind of work through this here.
So I think that you had to start out knowing the fact that like obviously the AV node is going to be supplied by the right coronary artery, but I don't know if you're right. Like it says angiography shows a left dominant circulation, which is actually uncommon, right? That's the uncommon one.
I think so. Yeah, I think that's the uncommon. And then 90% of the artery supplying the diaphragmatic surface and the AV node of the heart. So take a look at here. This is in my mind what I'm thinking, right? So if I'm drawing the heart, right? And you want to split it like this, right? Your AV node is something here, right? SA AV node. And then it says the diaphragmatic surface of the heart, right? If your, left ventricle is here, right? Which is somewhere over here, right?
Yeah.
So inferior, right? So now they're trying to say this artery that you're trying to get, right, deals with this whole circulation in this area, right? So you picked right coronary circumflex and anterior IV, right? Left anterior descending. That only does kind of the IV septum and anterior wall of everything, right? But it doesn't hit this bottom portion, which is the diaphragmatic surface. So you got to pick an answer choice that gets all the way down there, right? And the only one that goes all the
Mhm.
way down there is this posterior intraventricular area, right? That gets at the very bottom of the heart, right? And also the back of the heart. You,
Okay.
you get what I'm saying? The key thing is getting all the way down to the diaphragmatic surface. So your answer is good up until the IV septum, right? Which is kind of right here, but it doesn't get all the way down here. You need to pick an answer choice that reaches all the way down there. I think the trick
Okay.
question is this left dominant circulation, right? The circumflex artery gives rise to posterior descending artery. That's going to be kind of your weird,
That's okay.
that's the trick, quote unquote, trick of this.
Okay. Makes
Yeah.
sense. Makes sense. Makes sense.
Yeah. Weird question.
Um, I just didn't know this one at all. It said a 1-month-old boy is X-linked severe. He has SCID. Um, and he's enrolled in therapy. Bone marrow stem cells are extracted for the patient and are treated with treated ex vivo with a retrovirus expressing the wild type gene. Although the patient initially responds well, 30 months after the treatment, he develops a form of T lymphocyte leukemia. Molecular studies show that the T lymphocytes are monoclonal. Which of the following viral processes is most likely to cause is the most likely cause of the leukemia in this patient? I just didn't know this at all. Like I kind of took a guess. This is my like, oh, I just don't know, and I took a guess.
Sure. Trying to think.
And I saw P53 and I was like, that's a lot of issues with tumors, and so I just took a guess at that. Like over half the tumors in the world, I think, are like P53 errors.
Integration injection to oncogene. I'm trying to come up with something clinical to help you here.
Yeah.
Let me see. Okay. So this is a couple things, right? This is kind of interesting. Okay, so I can kind of help you here to kind of help break these down a little bit better. Sometimes these really scientific things are really
Yeah.
really annoying, right? So you know that the patient has skid, right?
Hmm.
Okay, skid as in you know that it deals with B and T cells. That's kind of what
Yeah.
skid is, right? B and T cells are the severe combined, right? So you're dealing on both sides of the spectrum, right? Of B and T helper cells, or B cells and T cells, which are not good, right? You're going to get sick of everything, right? So then you follow it, right? Then what they did was they took some of the stem cells from this kiddo and then put a retrovirus, right, into to introduce the gene that could correct the skid. That's the idea of genetics, right? Or gene therapy, I guess, right? But the issue with retroviruses, right, or as you already know from kind of all your basic science, the issue is that these are not precise a lot of times. So what happens? You always wonder that if you introduce a gene in the incorrect spot, what can happen, right? That's what they're trying to test you
Yeah.
on, right? And then obviously, of course, right, they say after initially responds well, he's not sick, etc., but then all of a sudden forms leukemia, right? And then they're monoclonal, which obviously, right, leukemia is going to be the same cell line that generates over and over and over again, right? Which they're just saying it in scientific terms that they're monoclonal, which means it's leukemia. Okay, so now the question is, they're trying to figure out, okay, they're trying to test you. Do you understand how retroviruses introduce genes into another cell line, right?
Hmm.
So the best answer would be integration into an oncogene that's close, which means that you activate it and it's going to replicate like crazy.
Yeah. Okay.
You
Because
understand what I'm
that
saying?
oncogene is like a cancer-causing gene, and if you,
Yep.
yeah. Okay.
But
Okay.
one of the key things is this integration, right? Because that's really what you're doing, right? You're taking the retrovirus to dump a new gene that is correct into these cells. And so it's kind of asking, if you're like, oh, I know retroviruses, integrate genes into other genes, then that's kind of what they're trying to ask you.
Okay. Okay.
AK, do you know what gene therapy or what it consists of? That's pretty much the quote unquote kind of
Yeah.
methodology of
Those are
it.
tough, but yeah, that when you kind of break it down like that, it was like
Yeah.
that's not as bad. Oh man, this was frustrating because I just read it the day before too, and I still missed it. I think it was just talking about like a CT scan shows a cyst-like dilation of the fourth ventricle, hypoplastic cerebellar hemispheres, and enlarged posterior um, fossa with high tentorium cerebelli. Which of the following subdivisions of the neural tube is most likely affected? And I didn't actually even get a diagnosis with this. I just said I think this is just asking. I actually don't remember what this is asking.
Yeah,
100%.
they were just saying, working through this, right? The pons, the cerebellum, the fourth ventricle, where is it, the embryologic origin. So this is a memorization thing, not really too much clinical.
Yeah.
So
Yeah.
I mean, this is, I think this is Dandy Walker. This might be Dandy Walker.
Dandy Walker. Okay.
Yeah. So
Enlarged.
sometimes they do mention this. I mean, you can kind of memorize it. I'm not great with some of the neuro diagnoses, because some of them are just so bad that I'm just like symptomatically, I'm like, man, they have so many issues wrong, right? I mean,
Yeah.
you know what I mean? It just all groups and it's like, man, they can't walk, right? They can't balance, right? They're intellectually delayed, right? It's just all these bad
Yeah.
things, right? And so I lump them into one thing, and obviously that's not the correct way to do it, but yeah, sometimes I look at this and I'm like, yeah, Danny Walker, bad diagnosis. That's all I remember.
Yeah.
But yeah,
Oh my gosh, this is very embarrassing. Anyway, it was talking about this person had a chronic otitis media, and that's usually caused, I mean, just like I know this from H. influenzae, versus external is like Pseudomonas. But this person has like throat, basically they had otitis media, and I think it was caused from like a infection in their throat um before, like 8 days before. And it said how did it get there? And I was thinking, I'm like, I don't know if it's nasopharynx or if it's a laryngopharynx. And I didn't think it would just, I kind of got confused of where external ear, middle ear, and inner ear at that point started and ended. And
sure.
so I kind of said probably the inner ear first, and then it got to there. But so I went
So
with that.
let me teach you this because I can't have you be missing ENT questions, right?
No.
This is against kind of who I am as a person. So here's the ear, right? We'll start here. Here's the external auditory canal, right? EAC. Okay, here's your tympanic membrane, your TM. Okay, that separates your EAC from your middle ear, right? You have your malleus, your incus, right? And then your stapes.
Babies. Yeah.
Okay, and then right that attaches kind of to your cochlea, right? On your oval window, your round window somewhere here, right? This is getting a little bit too much, but this is your middle ear. This is your inner ear. Okay. Your middle ear, okay, connects. It has a tube that connects, right? If you can imagine, here's your ear, right? Right. It connects from here, the middle ear, to the back of your nose. Okay. So if I draw, this is gonna get real wicked here. Here's your
No,
eyes,
we're good. Yeah.
here's your nose, right? And here's kind of your mouth somewhere here, right? And you're kind of looking to the side, right? So here's your nostril, right? Okay, draw this as best as you can. Okay, so here's your nasal pharynx, right? And if this is your mouth, this is your oral pharynx, right? Okay,
Oh yeah.
it should be something like this. Okay, so if you have strep throat, your tonsils are here, right? And so that's very close to your adenoid tissue, which is up here. So if you have an infection, this can inflame all the way up to your middle ear, right? Your inner ear, right? Inner ear kind of issues usually either comes directly from your middle ear, right? And then transfers to your inner ear, right? And then, of course, your inner ear, right? It drains into kind of part of this is created by your CSF. This gets way too crazy, but if you get an infection in the middle ear that's bad enough that gets into your inner ear, it can cause you meningitis, right? Because your brain sits somewhere right here, right?
Yeah.
So, best answer here, without going too crazy into more into ENT, is going to be from nasal pharynx because you have a strep throat, right? Which is your oral pharynx, which is close to your nasal pharynx, right? Travels up your eustachian tube or your auditory tube, and then connects to your middle ear.
Middle ear. And so, I mean, obviously, otitis media is middle ear infection, right?
Yep,
Otitis
exactly.
externa is external ear infection.
Yep, which is over here.
Yeah,
Yep.
perfect. Okay.